Thank you to everyone for joining today's open discussion forum. This is our first event of its kind to allow for discussions to be focused on you, psychological professionals working on inpatient adolescent mental health wards during the COVID-19 pandemic. The purpose of this session is for individuals to engage in conversations around particular issues and to learn and share good practice within inpatient adolescent mental health wards. Before we start today's session, I'm just going to run through a few housekeeping points. Please ensure your microphone is kept on mute and your camera is turned off unless you're speaking. This session will be recorded and we will share the recording with the slides after the session. You can contribute to the discussion by raising your hand and we will let you know when it's your turn to speak. If you're joining by telephone, please press star followed by 6 to mute or unmute yourself. If you prefer not to speak, please type your questions and who you are directing your question in the meeting chat box. We will read them out and answer them live. And we will try and discuss as many questions as we can during the session, time allowing. We're firstly going to begin with a presentation by the lead contributors of the guidance document. So it is my pleasure to introduce Catherine Berry, who is a Professor of Clinical Psychology at the University of Manchester, Jessica Raphael, a Senior Research Associate with Greater Manchester Mental Health, and Rachel Winter, a Research Associate with Greater Manchester Mental Health. And unfortunately, Jennifer Adams, Clinical Psychologist, couldn't join us. And they will be elaborating on the 3 key areas of the document: defining the role of psychological professionals during COVID-19, support provision and access to digital technology. Take it away, presenters.
Okay, so I'm going to talk through the first few slides focusing on defining the role of psychological professionals and the data that we gathered to inform the guidelines. So Arun, if you can go to the next slide, please. Okay, so just a bit of context about where the guidance came from. We are currently doing a randomised control trial looking at delivering psychological therapy on inpatient wards. So we were aware through that research of a lack of standardised guidance for psychological professionals working on these wards during COVID-19. And we were aware that there was research and guidance out there saying that, particularly by the BPS, that people should be going to remote working. We heard that there was some issues around this, particularly with the inpatient wards, based on some wards with limited remote access, no conferencing facilities, inpatient difficulties. So just to provide further context, this was done on all inpatient wards. So we were looking at PQ, adult mental health, and I know this is specifically about children and young people. So in children and young person services, there was slightly better technological support for people in there. And also just people's vulnerability and capability of following guidelines like social distancing when people were going on wards. So we heard from psychological professionals that there was a difficulty between balancing continuing delivering psychological support and then also reducing virus transmission, and people concerned that if they were going to go onto these wards that they could help spread the virus. So effectively what we wanted to do was develop some guidelines for clinicians to use as and when needed within their services. So some people may have already had some direction from their management, whereas others were less sure about what they should be doing. So we gathered information from a wide range of media. So we did some group consultations with psychological professionals. There was 3 sessions that we held, and we held them on Zoom. And there were 23 professionals, I believe, who attended, a mixture of different services, including children's services, a mixture of different kind of professionals, so clinical psychologists, art therapists. And then what we did was we also had individual consultations with staff working on wards and patients on wards. So there was six patients and 4 staff members we were able to do telephone consultations with. We did a rapid review of the literature just to have a look at what mental health wards should be doing to adapt their services during COVID-19, and previously, we looked at papers that talked about Ebola outbreaks and what they did to adapt services. And we also did an online survey and we took that information that we found from the group consultations to inform an online survey that was then distributed UK-wide to different psychological professionals working on inpatient wards. So that's where we got the data. And from that, sorry, yeah, next one, please. From that, there were three main kind of themes that came out of that, and one of them was defining the role of psychological professionals, which I'll talk about next. So if you could do the next slide, please, Erin. When we were speaking to psychological professionals and staff and patients, a lot of people spoke about them being essential to working on the ward, and this particularly came up where people had had a directive from potentially management saying that to avoid transmission, they should remain and work from home, do remote working where possible. So one of the things that participants were keen to stress was that they are essential to the ward and should remain on the ward where possible, in a number of different capacity and forums. However, there is a lot of variance within that depending on ward circumstances and person circumstances. So we'll just touch on that briefly. So some people talked about working remotely across all wards, and the next couple of slides I can talk about the benefits. Sorry, if you could go back, the benefits of doing that. Some people talked about working physically on one ward and remotely on others. Again, I can talk about the potential issues on the next slide with doing such things. Where people had large resources, they were able to split psychological teams so that one member could work per ward, but we're aware that actually within clinical professions, psychology on wards, it's quite limited resources, so that was very minimal that people were able to do that. Working remotely the majority of the time and then short periods actually being able to go onto the ward was another thing that people said they did. And also people were talking about travelling across wards in one day directionally, from going from low risk wards maybe where there was no instances to maybe the last ward of the day where there was a couple of instances of the virus being on the ward. So if you could go next slide, please. So for those working face-to-face on the ward still, whether it be every day or minimal input going on, they found it essential, and that was just so that they could continue to deliver psychological input at all levels of the system. So we know historically, based on the research that we've been doing, psychological professionals do struggle just delivering, support just to patients, based predominantly on the medical model, and they felt that being face-to-face and present on the wards was really important so that they could get the support and the work across that was part of their role. Okay, next slide, please. So people mentioned benefits of face-to-face, so they were more available to see staff and patients. So we know that inpatient wards are a very busy environment. There could be one incident where something might have been previously booked and then somebody has to go and deal with that incident. And actually the psychologist being there and being adaptive and being responsive was really important, and to do that they had to be on the ward. They were able to contribute to informal check-ins with staff. So again, issues of staff not being able to release themselves to go and attend a formulation session or just to get support from the psychologist was really hard to do if the psychologist wasn't on the ward, because they were there and able to react and adapt to that situation. People stated that it actually improved relationships with the ward and service users, because they were seen to be part of the team. They were there, they weren't leaving the ward and working from home. They were integrated in the team, and it also reduced the risk of cross-contamination across the wards. I'm not too sure at that point actually, because I feel like going onto the wards doesn't reduce cross-contamination, so I'm not too sure if that should be there. With regards to the challenges, a lot of people talked about the infection control measures that they had to use whilst on the ward. So using PPE, so people having to wear masks, and the difficulties that had with staff adhering to those rules, but also with patients, specifically the children's services, them not liking people wearing masks across their faces, the issues with communication. People in children's services did also describe them having to all of a sudden wear uniforms, and that children didn't like that because when they were out with Staff members, they didn't want to be associated with having been on a ward or being with a nurse or being with a psychologist. So there were some difficulties around patients being accepting and not liking the fact that psychology was all of a sudden wearing a uniform and identified with being kind of more of a medical member of staff. Where people were only working on one ward, there was obviously ethical considerations about unequal access to psychology. How do you pick a ward which does or does not get face-to-face psychological input? Service users' access to private space for remote therapy. So this was an issue where, you know, somebody couldn't do it in their bedroom, or there was no rooms on the ward for them to go into and do it privately, just because of the lack of space that we're aware that there are on inpatient wards. And also psychology staffing resources. So that goes back to the, you know, if you've only got one of you and you've got 5 wards to work across, is that really feasible to reduce transmission of spread? Things that when people were going onto the wards, they were saying they need to consider was additional support for service users without leave. So in a lot of the wards, we found that visitations from family members and leave were reduced, and this had a negative impact on service user mental health, and therefore psychological therapists should think about providing additional support to those, even for those who were kind of locked in their room because they were shielding, or people who had symptoms and therefore there was reduced contact with them. One idea was that ward staff could look to provide psychologically informed interventions with the psychologist supporting, either remotely or face-to-face still, just to kind of reduce footprint of going onto the wards. And the access to IT was still really important. So one child ward did talk about attending ward rounds, and whilst they were still face-to-face, the child was in a different room with another staff member, and was able to get access to a laptop to kind of remote into the room, even though it was next door, to avoid the large amounts of people being in the room. So that was a consideration. Okay, next slide, please. Go next slide, please. Thank you. So remote working, so psychological professionals were weighing up possible risks to service users themselves and other staff members by them going on the ward, and therefore in some circumstances taking into account all of the ward circumstances and all of their own personal circumstances and the client population. People did sometimes deem remote working to be a safer option. So if we could go next slide again, please. So some of the challenges were with remote working was that psychological professionals sometimes felt disconnected or forgotten, and that's just because they weren't on the ward present. We did find that often where people hadn't been working for particularly long lengths of time on the ward and hadn't already established that relationship and rapport, that they did struggle with this more than others who had been on the ward for longer. They tended to receive fewer referrals, both from staff accessing their support, but also service users being put forward to receive their support. They found it a lot harder to provide informal support. So we had psychological professionals saying that something would be arranged and they'd try and phone to see where everyone is, and obviously phones, it's really busy, it's hard to answer the phone, so they didn't quite know what was going on in the ward to offer that informal support as well. And it was hard to continue their usual psychological activities remotely. I think I would say that we did find it less of an issue with children and young persons, just because children were more aware and user-friendly with technology, but in some cases it was still an issue for some people. The benefits of remote working, a lot of psychological professionals said that all of a sudden they were able to attend a lot more meetings, and attendance to those meetings benefited the service user well-being. It involved attending meetings remotely due to the number of people in a contained space, so you could actually get more MDT people in one room via remote technology than you would have prior, which gives a lot more holistic care and picture to that person. And they were able to not have to wear PPE. So a lot of the clinical professionals talked about issues with being hot and stuffy wearing PPE in the barriers between communicating with service users. So actually not being able to wear PPE was beneficial for them. Okay, next slide. I'm going to hand over to Catherine now, who is going to talk about support provisions.
Okay, so support provision was the next section of our guidance and the next theme that came out of the consultation work and the review work that we did. And it refers to both support provisions for staff, service users and families and carers. Next slide, please. So all psychological professionals that we consulted reported that there was increased opportunity for or increased requests for them to provide support around staff wellbeing on the ward. So I think it's a really positive thing that psychologists have been recognised for the skills, not only in relation to service users, but also in relation to general mental wellbeing of staff on the ward as well. And I'll talk about some of the different aspects of support that people got involved in providing or are still currently providing. Next slide, please. So these people talked about 6 different aspects of support. I'll go through these in turn in the next slides. So the first one was Wobble Rooms or Novid Rooms, which are essentially the same thing, which is creating an environment in a room off the ward or attached to the ward, where staff can take a break from the busy, hectic environment, and it was providing things in there to help them relax. So snacks, soft furniture, magazines, music, and also staff support phone numbers as well for the trust support services or external support services. And there's a kind of unwritten rule within those rooms that people don't talk about COVID or the pandemic. So just a place to go and chill out and spend some time de-stressing from the busy, hectic environment. Self-help resources. Lots of colleagues got involved in developing self-help resources, and there was quite a lot of different things flying around the internet and via emails from trusts, from organisations, but psychologists were involved in trying to pull those resources together in a more digestible form for staff. So that included things relating to their own self-care, sorry, you can just go back, but also going home checklists, which is trying to help staff separate the stress and anxiety that they were experiencing on the ward from their home environment and leaving some of that behind them if possible. And that was shared to staff via wellbeing packs, which some colleagues developed, or also via email with a number of different resources. So the role of the professionals wasn't necessarily to develop new resources, but to create a manageable amount of resource for the staff on their wards rather than feeling kind of overwhelmed. Walk and talk. This is something that's probably used more with patients originally, but staff reported that they were using this with staff. It's just an opportunity to have informal conversations with staff while walking off the ward, so taking a break from that busy, hectic environment. And also the activity of walking provides a medium to perhaps have some conversations, an easier medium to have conversations with people, because you're kind of focused on walking. It's not sort of sat down one-to-one staring at somebody, so it's just it can help people talk, and we know it can help patients and service users talk, so people started applying that with staff as well. Reflective practice. This is something that's probably happening on lots of wards anyway, but then people were using the opportunity to really ensure that reflective practice happened, and that people had the opportunity within that to talk about how they were feeling about the ward, their own anxieties around COVID, their own extra pressures that it created within the ward environment. And obviously reflective practices typically takes place in a small space with a significant number of people, so people had to be creative about how that was being provided, such as open air spaces or held in larger rooms with social distancing. And people talked about the importance of it needing to be consistent, so it wasn't something that was scrapped because something else was going on in the ward, but just about being flexible. So even if it couldn't happen exactly when it was supposed to happen, it should happen at some point and not kind of get pushed to the side, because it's really important for maintaining staff wellbeing. People also talked to us about 20-minute care spaces, which I guess has overlaps with kind of reflective practice, but it's around a Andy Bradley's compassion circles model, which is providing small opportunities for staff to support and care for one another and recognise them how stressful their job is, and to apply that self-compassion or compassion to themselves. Next slide, please. As well as support for ward staff, which I think isn't always as well recognised by our colleagues as part of our role, but in addition to that, people also talked about providing additional support for service users, or being asked to provide that and to look after their well-being, which for some people was challenged as a result of the restrictions that were in place or the anxieties around the pandemic. Next slide, please. So this support took a number of different forms. Firstly, in the form of one-to-one interventions. Can you just click the next slide, please? So this was people continuing to provide one-to-one therapy with people, either remotely or face-to-face. And that might be focused on mental health issues aside from COVID, but also anxieties that resulted from the pandemic. Or also more informal interventions such as walk and talk with service users as well. And we know within inpatient settings we have to use a whole range of ways to try and engage people in therapies. So people were telling us that they were doing, I guess, similar work to before, but being asked to do it, perhaps to do it more. So communication, next slide please. People talked about how in terms of service user support, there were the values of providing clear and simple information about COVID and the reason and the rationale for ward-based changes to service users. A lot of service users attributed the increase in restrictions to staff themselves as opposed to government guidelines. So wards really valued opportunities to, or patients or service users really valued opportunities to have regular updates about government guidance and the reasons for the restrictions, and kind of open meetings and open discussions with opportunities of questions and answer sessions for staff, even though the answers weren't sometimes weren't straightforward. In terms of least restrictive practice, psychologists were keen really emphasising the important role of, particularly given the risk of physical transmission of the virus, of really the importance of least restrictive practice and not using restraint. Obviously, psychological professionals would be advocating for that anyway, but it really highlighted the increased need for that and trying to de-escalate situations before they need to result in restraint. And I guess just helping prevent the need for restrictive practice by kind of helping people manage their anxiety levels, helping people regulate and control emotions through group work, helping staff understand where service users are coming from so they're less likely to engage in behaviours which might aggravate the situations. So you're doing that through psychological formulations. Okay, next slide. Group work. People told us that group work was especially being valued. The difficulty for some people was the physical space to carry out the groups. So people looked at providing groups within outdoor spaces or restricting the number of attendees into the actual group, bearing in mind social distancing, and then offering the content of the group one-to-one for those people that couldn't attend. And groups varied in terms of the topic and content, but they were responding to the needs of the ward. So if staff had noticed an increase in people's anxiety about COVID, then psychologists were getting pulled into providing groups around that particular topic or that particular area of concern. And that's something that was really valued by service users as an opportunity to actually not only learn the material or learn new information from the psychologist, but to learn from each other as well. Which is particularly important, I guess, when people weren't having much contact with the outside world. Next slide, please. Psychologists talked to us a lot about indirect interventions, and we know that as ward psychologists we provide a lot of indirect interventions anyway, and this was especially important in terms of provisions around the pandemic. So people talked to us about how they continue to deliver team formulations and how they'd achieve that both virtually and face-to-face in rooms that permitted sufficient separation from staff or wearing of masks where that wasn't possible. psychologists got involved in helping staff develop COVID-19 or isolation-specific care plans, because obviously as a result of some of the restrictions, increased people's stress levels, which also had a knock-on impact on, I guess, levels of risk within service as well. So it was helping tweak people's care plans around issues raised by COVID. As Jess mentioned, some staff were, or some psychologists were supervising staff to deliver psychosocial interventions, so they might not have been going on to a ward as much themselves in order to reduce the footprint on the ward, but they were supervising others to deliver psychological work. And there was psychologists were having increased contacts with families and carers, and supporting service users to contact their loved ones remotely, because of obviously the restrictions wards were placing on visitors. And also in some of our later life services, we'd had people report a significant number of losses, so there was increased need to provide bereavement support to families as well. There was more liaison as well with community staff to support discharge, because a lot of wards opted to minimise their admission rates and to get people back into the community as soon as possible to lower the physical risks of having a large number of people in one small space. Okay, next slide, please. I think this is your slide, is it, Rachel? I got that right, yeah. Okay.
Yes.
I'll hand over to Rachel.
So as Catherine said, there was increasing support from psychological professionals to family and carers, and this was particularly related to restrictions on the ward, such as stopping visits or service user leave. Next slide, please. The sort of support that psychological professionals spoke about for families and carers included increasing the frequency of carer contact with professionals to provide updates, and this was about providing updates on the service users' well-being. There was also, as Catherine mentioned before, facilitating increased contact between service users and families via the phone or video, and on wards they were using a ward phone or a ward tablet and allowing increased access for service users to be using them. They were also providing families with information such as through leaflets or letters, making sure that this was written in an accessible way for the family members. And these were often outlining the current restrictions on the ward and the rationale for these measures, such as why leave was being restricted. They were providing psychological support for families too, and this included online groups for families where they could support the families and families could support each other too. And there was also the increased use of creating bereavement packs for carers and families if they lost someone whilst they're on the ward. But not only did psychological professionals help all those other groups, they also had to think about the support they needed themselves. And so it was important to consider how they could support themselves to reduce the likelihood of exhaustion and burnout. And the form of supports that the psychologists were telling us about was connecting with other psychological professionals, and this was within their trusts as well as outside of the trusts. And this was about connecting with others to learn from each other, so what was working well, what they were struggling with, and also providing peer support for each other. There was also in community psychological professionals being involved in these meetings as well to provide additional support. So community teams were offering inpatient psychologists and staff on the ward support and support sessions, and also telling them about the services that they were offering in the community. Some spoke about how they had increased the number of clinical supervisions that they were having. There was also increased use of accessing and contributing to online webinars on relevant topics. So this included things such as discussing how they could provide remote therapy, and again, exchanging ideas about what was working or what they were finding more difficult. And there was finally facilitating and partaking in remote CPD days with other psychological professionals. So throughout all of this, and everything we've been talking about, obviously the idea of digital technology has come up throughout it, because this was being used to connect all these different groups together. Next slide, please. And this was to support both staff and service users. So psychological staff were obviously required in these unexpected times, rapid access to appropriate technology from their trust, such as having adequate internet and adequate computers too. And this was for them to continue their role as a psychologist, but also support the well-being of ward staff. A lot of the psychologists that we spoke to felt that remote attendance at meetings was actually working really well. This is because it was increasing the attendance of people to group meetings, because they didn't have to travel between the meetings, so it was more efficient, and also it was more cost efficient too, not having to move between different meetings. And actually a lot of people said that continue. Psychologists also felt that they had established a deeper relationship between inpatient and community teams, because they could share more information between the two groups. And the remote meetings also allowed for care coordinators and other clinicians to attend when they may not usually. Again, this was because of being able to get everyone together in one virtual space rather than having to move between wards and the barriers that this can cause. Digital technology was also considered in supporting family and carers, and there was benefits of providing service users with technology, which helped to not only increase engagement with their family members, as we mentioned before, but also with staff involved in their care and psychological professionals. So providing the telephones and the laptops and things like that for service users to increase interaction with family members and friends was found to be important. But also psychologists spoke about how patients could contact psychological professionals more frequently. So we had the example, for instance, of a service user telling us that their psychologist was ringing them just to check in to see how they were, and how they actually found that really beneficial, because the psychologist couldn't come on face to face as much. Having that phone call check-in they found really useful. There was the more structured remote psychological therapy meant that actually some service users felt a reduction in anxiety, because they were worried about virus transmission if they were meeting face to face. And also for the psychologists themselves, having this remote therapy combated some of the challenges of PPE, such as the discomfort that they felt. And for service users and the psychologist, having PPE could be a barrier for communication too. So again, that combated the barriers of communication. Finally, service users engaged with professionals from outside the ward. So they could, this promoted safe and timely discharges, because they could hear about what their care would look like when they were off the ward. So Jess, would you like to summarise?
Yes, can we have the next slide, please? Thank you. So we had to think about what the key messages were from the guidelines, as there was a lot of data and a lot of points that all professionals and all service users identified. The main concern we found from psychological professionals was whether or not they should work remotely or directly on the wards. And that was because in a lot of cases they didn't have a direct steer from management. And across the board there was differences between different trusts, different wards, and who was doing what. So within our guidelines, we suggest that decision should actually be made by the psychologist with senior support and taking into account each ward and personal circumstances. So there shouldn't be a blanket rule. Having said that, we do advocate, based on all of the data that we gathered, that at least some direct work continues on ward, just so that psychologists are there to be able to continue to provide support to staff about psychological ways of thinking, and to really help change that medical model that's so predominant often on an inpatient environment. People did raise that throughout the pandemic there has been a lot of stress placed on psychological professionals to be innovative and to be heroes, and that was echoed through our consultations, that people felt that pressure. So it's really important for psychological professionals to access that support, peer support, usual supervision. And actually the group consultation participants did say that they had found it really beneficial taking part in those group consultations, just to hear that other people were going through the same difficulties that they were. Looking to increase staff and patient support through informal channels where possible. And that's something we've promoted through our research anyway, but just it's really important, those snippet conversations, those check-ins that Rachel mentioned, like informal conversations via calls with patients, walk and talk was really beneficial for people. The patient groups are considered important, and if not already established, would be a good way to do peer support. So a lot of people talked about the fact that they were trying to continue patient groups as much as they could, and other people talked about the benefits that they'd heard from other people about using groups and they weren't already established, and actually they were going to try and set those up using outdoor spaces where they only had small access to small rooms, or trying to book large indoor spaces and limiting the amount of people that were in attendance. And I think a lot of that was due to the reduced visitations, especially in children and young person services. They weren't used to not seeing their family members so much face to face, so they found that really helpful. And then access to good technology, as we've heard from Rachel, is just really important to support going forward within wards. I'm not sure it was within children's services, but one person was talking about the fact that they still use paper records. So obviously that psychologist could not work from home because they could not access that patient record. And actually a lot of people talked about the fact that technology had been made readily available, which was in contrast to what they had usually found through governance processes, and that everything had been sped up, and they were keen to make sure that that continued going forward, and that wards had access to things like tablets for children and young people going forward. So I believe that is the end of that talk, and I think is Matt going to help us facilitate discussion now?
I certainly am. Thank you very much, Jessica, Catherine and Rachel, for that informative talk. And useful key messages that hopefully we can take away. The floor is now open for questions from any of our attendees. So please use the raise hand feature or use the chat function. And if you are using the chat function, just tell us who you're aiming your question at. Okay, while we wait for those to come in, I wonder if I could ask a question. You mentioned in your key messages that psychological professionals were experiencing kind of added pressure around this societal discourse around being heroes. And I wonder if you could expand on the extent to which that's affecting attendees and yourselves to manage expectations around capacity and provide additional support.
Who's taking that one? Am I taking that one?
Anyone?
Catherine, do you want to chip in at all?
Would you want to give some context about where it came from, and then I can give an opinion on it?
So part of it was the innovation and psychological professionals feeling a lot of pressure to be innovative. You know, we've already got an established good service. Can we not continue that where we can? Why are we having to come up with all these packs? And a lot of inpatient psychologists in particular were talking about the fact that some community colleagues were working from home and therefore had less to do, were churning out all this new material, and therefore they felt pressured to do the same thing even though they were going onto the wards. So that was one aspect of it, and the other aspect of it was even our consultations themselves, and saying that guidance was needed, people querying whether that was a reality and why couldn't they not just continue it as usual, why does it need to be considered, and the fact that within a lot of our discussions we found that a lot of psychological professionals were stressing the importance of going on to wards, and therefore there was pressure for those people that actually it wasn't suitable for due to the ward circumstances, their own personal circumstances, and they didn't feel like they should have to make that decision to put themselves in harm's way, you know, due to the pressures that they were feeling, really. So that was where that came from.
Yeah, I think there was a lot of people were torn, really, weren't they, from wanting to be seen to be out there and doing something on the front line, versus obviously anxieties and reservations about that, but then a sense of guilt if they weren't in that position for whatever reason, through their own choice or through the choice of management.
Mm-hmm. I would say that a lot of that comes from just being a psychological professional, and they're a very reflective group, and they're there to do a job to help people, and therefore that I would say there's a pressure on themselves instinctively anyway, and that they're there to support and deliver a service. And if there's something that's a barrier to preventing them from doing that, that would cause internal pressure and conflict within somebody.
Thank you. Do we have any questions from the floor?
Hi, it's I work in a campus inpatient service, and I guess I don't know whether it's a question or more of an observation, but one of the things that we found in particular was the crossover of roles, that because we were on ward more, is the need to get involved with more the healthcare role as well, and how that impacted the relationship. And I just wonder whether that was something that was fed back to yourselves as well.
Yeah, that definitely came up. So we had a lot of people saying that, so when I was talking about defining the role of the psychological professional, a lot of people were talking about being pulled into different kind of healthcare roles due to lack of staff, kind of doing observations. So where that did happen, people talked about using it as an opportunity to kind of do some lower level psychological work. So throughout observations, having those talks with people, trying to, and some people even talked about targeting the observations with particular service users that they knew might be good at or willing to wanting psychological support, and that was a way for them to build a rapport with people. Where it did happen, people did talk about the benefits of it and being able to be seen as kind of mucking in, as so it would say, and getting involved in other aspects of the ward, and that actually really helped with service user relationships and with staff relationships as well.
Okay, we've got a question from Liz.
Hi, so it wasn't really a question so much as just thinking about I've been remote working completely because of my own health condition, and I am due to kind of move to part home, part in the building soon. And I think it was just kind of in reflection with the staff, just that nobody's really got it easy. So the people who are at home, there's things that are really frustrating and difficult for them, and vice versa for the people who are on site. But I think reflection's been really helpful to kind of make sure all of those things are being heard by all the different people. And the other thing I just wanted to say is, like, stepping into new roles. Mine's been sort of like IT support. So I found it really irritating, but I'm the best at using Teams, even though I'm not that great really. So everyone's always like emailing me in meetings going, can you add me to this meeting? Can you tell me how to invite this person? And all that kind of thing. So just kind of those things that actually it's probably taken up a lot of my time over the last few months that normally would never be anything to do with me at all. So just kind of reflection really on those things.
Yeah.
Thank you. We've got a question from Paul.
Yeah, hi there. Sorry, I missed the beginning part, so you might have covered this, but was there anything about the impact of psychologists not being in the ward in terms of collecting outcome measures, in terms of new ways of doing that, or anything about that?
We didn't actually cover that in any of our consultations. However, as researchers, we face that challenge anyway. But obviously that's more about kind of quantitative outcome measures rather than anything observational. So with us, we ended up going to telephone measures with people, and with I think Rachel and Catherine will be better advised to say how that's going for them. With observations, I know that currently I'm working in a community children's service, and they are finding that they're able to use Attend Anywhere and kind of watch children in the background doing observation outcomes. But again, things like cognitive assessments are being less readily done remotely.
So is that what you meant, Paul, about how easy it is to do outcome measures, or did you mean outcome measures as in evaluating services?
Well, I guess it's both, really. My first thoughts were about collecting outcome measures and coordinating those from the young people on the unit, from the patient, so clinical outcome measures, because it's psychologists that, as we know, are the people that tend to get those done. So I was thinking,
Yeah.
did you detect an impact of that, and did you find any innovative ways to do that? But equally, often it's something that we do as well in terms of service evaluation type outcome measures.
Yeah, I mean, as Jess said, it wasn't necessarily looked at as part of the interviews, but it's certainly something that's come across from our research, because we're essentially evaluating the impact of psychologists on wards, and to do that we're administering outcome measures with staff and service users, and we've been doing that remotely because the trusts wanted to reduce obviously the footprint on the ward, and having research staff on the ward wasn't seen as an essential activity. So the researchers have been relying on ringing the wards to try and get people to fill out outcome measures over the telephone. It's actually worked relatively well in the community settings, but it's proved a bit tricky on wards. I think to get people to answer the phone in the first place, and then also to liaise with the staff about putting the service user onto a telephone when they haven't got their own phone. Rachel's been doing it, haven't you, and having to ring the ward multiple times a day to get in touch with staff about service users, and service users not answering the telephone. It's been quite frustrating, I think, hasn't it, actually?
Yeah, I think if you spent any time on the ward, you realise how busy staff members are going in and out of the nurse's office. So trying to get a moment where a staff member is there to get in contact with can be quite challenging.
Yeah, because I guess we all know how hard it is to get outcome measures done when you're physically on the ward. So I was thinking,
yes.
When you're not, any hope is gone.
Yeah.
It's a bit dramatic.
Yeah, I mean, we have managed it, but it's been just down to the persistence of the research staff, and that's literally phoning wards every 4 times a day, 5 times a day, is it, Rachel?
Yeah, at different points in the day, seeing if we can manage to get a member of staff.
I suppose I was wondering whether you developed any kind of remote ways of doing it, any online ways. I know that depends a lot on the measure itself.
Yeah, we have emailed them to people as well, but we haven't had much success with that. We've been better at trying to do it over the telephone. You could essentially set up a select survey as well, couldn't you, where you email the link to people, so they don't need to actually download the file and tick the boxes on the file. So that would be one way of doing it. So it's that sort of face-to-face contact that's really invaluable that we've kind of lost through this remote working, unfortunately.
I would say that the outcome measures were adapted so that for service users in particular, the researchers would phone the service user and then go through it with them, but the researcher would be inputting the scores directly onto the computer because they'd made it an editable form for them to do it. That could essentially also be emailed to the young person, but we didn't actually do that with the patients. We only because our research is adult only, so we were only doing emails to staff. But that could be one way at kind of editing the form so it was editable on Word or something like that, and then emailing it across to the young person to complete, maybe with an extra staff member there to support them, or somebody being on the end of the phone to guide them through it.
Liz, you had your hand raised.
Yeah, I was just going to say that I'd put some stuff onto Microsoft Forms, so some of the ROMs that we used, and then emailed those either to the staff to then do on the ward or directly to parents sometimes.
Which ones did you do, Liz? Can I ask?
I did the EDEQ and The trust, quite a few people in the trust had done a few of the other ones. So there was the SDQ, I can't remember what else.
Were there any issues around copyright and
there might be, Paul, but I just decided it was an emergency.
Right. Yeah. Everything else can go out the window, yeah. Like on our unit, we've got all our fire doors just wide open.
Yeah, exactly. So I think most of the ones are ones that you can get online anyway. So I figured they were probably okay. Mm-hmm. I've not done any kind of Pearson type ones. Mm-hmm. And just on the ADOS stuff, there is a thing called, let me just get the name of it right, because I might tell you wrong and then you won't be able to find it. Sorry, just looking. The BOSA, BOSA.
Was that the one from Kathy Lord?
Yeah.
Yeah.
So I think she'd said, someone had said that it's a bit better at picking things up with girls and that people had been doing it remotely, but I haven't actually done it myself. But if you've got ADOS training, you can download the training and information about it, and it uses the same record forms.
Okay, we've probably got time for one more question, if anyone wants to raise their hand.
If not, just going back to Paul's query about outcome measures, and Catherine asked him to clarify whether it was patient outcome measures or service evaluation. Greater Manchester Mental Health are also doing a service evaluation of inpatient wards during COVID, and for that they've just developed a paper questionnaire that they've got dedicated resource to go around and give to staff to give to patients on the ward. So just that's another way, and then they're being sent back to a central place.
Thanks. There's a measure that we use on inpatient CAMS called the WAM, the Ward Atmosphere Measure. Is it that one, or the Ward Atmosphere Scale?
No, it's one that's been developed just purely for the service. So it's looking at changes to services and people's perceptions of whether those changes are positive or negative, just to see if there's things that we can continue going forward. So it was a service-specific one that was developed.
Is that something that's freely available, or will that only become available after the research has been published?
It's a very good question. I'll have to ask. It was a colleague and myself who developed it, so I can ask him, because we will be looking to publish it. But I'm sure he'd be happy to share it as well. But I'll
thank you. I'd be really interested to see it. Thank you.
Okay, a big thank you to Jessica, Catherine and Rachel, our presenters for today, and those of you who were able to join the session. We aim to ensure that you can stay as connected as possible, and we hope that this generates helpful discussion both within and between your trusts. Don't forget to sign up to Knowledge Hub, which is an online discussion forum and our now primary resource space where you can access the following groups: our COVID-19 Mental Health Improvement Network, our QNIC and QNCC pages. If you're interested in presenting a webinar for QNIC, please email us at qnic@rcpsych.ac.uk. This webinar will be uploaded to CCQI webinars page within the next few days. And any questions that you have, just feel free to email us. Any questions we haven't covered, any areas you identify, and we'll add them as new threads to the QNIC Knowledge Hub discussion forum, where they'll be seen by our entire community of members and hopefully generate some good discussion from there. Once again, thank you for coming. Thank you to our presenters. Have a good day.